I'm very, very honored to be invited to speak about an issue which is very important to me, prevention of surgical site infection. And it's the first time for me being in Poland, so it is a premiere for me as well. I was asked to talk about the role of surgical gloves in prevention of surgical site infections. And I went already through the exhibition hall. I saw many, many new technology. But in fact, I'm talking about something which is very, very old, about the surgical glove. So most of you surgeons are, of course, very much familiar with surgical gloves. And surgical gloves, they play one important role, of course, which is to prevent transmission from bacteria from the surgeon's hand to the surgical site. But, of course, they have a second purpose as well. They can prevent, as a barrier, the transmission of microorganisms from the patient, from the surgical site, to the hand of the surgical team members. Now, of course, a glove will serve this function as a barrier if the barrier is intact. A couple of years ago, we performed a number of studies looking into the frequency of glove perforation. How often does it occur? So what we did was, over a period of 9 months in Germany, we prospectively followed about almost 900 surgical procedures. And after the surgical procedure, we collected the gloves of the surgeon immediately from the hand, and we looked for perforation of gloves. So we included a number of surgical procedures. We didn't look into a specific area, and we looked into laparoscopic procedures, laparotomic abdominal surgery, minor, moderate, and smaller surgical procedures, vascular surgical procedures, and cardiothoracic surgery. What we could find was a very surprising frequency of glove puncture. So you see that glove puncture occurs in after surgical procedures in about 15% in laparoscopic abdominal surgery, up to almost 1/3 in vascular and cardiothoracic surgery. So every third glove sampled after surgical procedures can have perforations, meaning that the integrity of the glove is not given anymore. Secondly, we found that there is a time dependency. The longer the surgical procedure would take, the more likely it is that you will have perforation rates. And if you look into groups, surgical procedures lasting less than 90 minutes, 1.5 hours, they have about 15% of glove perforation rate. If you have procedures between 91 and 150 minutes, it goes up to 18, and procedures lasting longer than 151 minutes, you have already 1/4 of all gloves are perforated. At the same time, we wanted to see what happens if somebody wears a glove without manual exposure and stress, like in a surgical procedure. So we donned 150 students in our institution with gloves during a lecture, during standard student lecture. They were sitting in the auditorium wearing the glove. After the lecture, we collected all these gloves, and you see that the rate was less than 1%, so it was less than it was 0.7%. So it is very, very clear. We have with latex gloves a fantastic barrier which is flexible, which can be sterilized, but the problem is it is not puncture resistant. The longer the procedure takes, the more stress is on the glove, the more likely you have a puncture. And where can you find these punctures? Interestingly, we always thought it will be on the dominant hand of the surgeon. You see that the most frequent site of glove puncture is the index finger of the non-dominant hand, which is very clear because you particularly find this in the first assistant of the surgeon. he will use his index finger to explore in the depth. This finger is exposed to sharp objects, and therefore the highest frequency you will find here, and then distributed on other areas. Now, is this clinically relevant? We know that there are glove punctures, we know this, but is there any implication on infection? Now, theoretically, it's of course very clear. Bacteria, they have two ways of entering a surgical site. One is endogenously, deriving from the patient. So here in this context, skin antiseptics, aseptic field of the surgical preparations are critical to prevent the transmission of the patient's own bacteria into a wound. And of course, exogenously from the environment. But the environment also includes, of course, the hand of the surgeon. And in case of perforation, it is very likely that there is a contamination. In such a case where you have a vascular graft, a prosthesis in place, which gets contaminated with bacteria, you might have the beginning of bacterial colonization, biofilm forming on the vascular graft, and in half a year or a year, you have a patient coming back with a fistula, with undulating fever and an infection. So the strategy up to date is we cannot sterilize our hands. This is impossible. But we can significantly reduce the number of bacteria on our hands by applying alcohol-based hand disinfectants. The problem here we have is that if you have your initial bacteria on your hands and you perform disinfection, you will rapidly reduce the bacteria on your hands, but still you have bacteria in the sweating glands and sebaceous glands of the skin. So over time, they will regrow again, which occurs about 2 to 3 hours. So after 6 hours, you have again the same number of bacteria as you had before your hand disinfection. Therefore, we have a problem that when we are wearing a glove and we have a glove puncture, the bacteria of your skin will go through these holes into the surgical site. Now, is there any evidence? There is only indirect evidence. There is a historic study by the pioneers of looking into modern surgical site infection prevention, Cruz and Ford, which was conducted in the mid-70s. And what you see is a study from the year 1973, where they looked into infection rate where gloves were intact. It was, let's say, 2%. And in surgical procedures with glove perforation, surgical site infection was 6%. So clearly there is a correlation. Secondly, I'm sorry for this slide. I'm not sure if you really can see this, but I will take you through this. This is a very recent study, a Swiss study published in Archives of Surgery 2 years ago, where Heidi Mistrelli looked prospectively into glove perforation and the outcome, surgical site infection. And they collected more than 4,000 patients in the study and followed these procedures. And they looked into the association of glove perforation and surgical site infection. What you can see is very striking. You see that if you have gloves where integrity was maintained overall, over all surgical infections, surgical procedures, you have 4% of infection with intact gloves. In the case of glove compromised gloves, glove puncture, you have 7.5. And if you substratify this into those patients who have received prophylactic antibiotics versus non-antibiotic prophylaxis, you see that patients who are operated without prophylactic antibiotics and the glove breaches with a puncture, you have almost 13% of infection compared to the same patients without antibiotics but with intact glove, about 3%. So this is a very, very important finding because we see that possibly in the view of antibiotic resistance, there is a way to improve reducing the administration of antibiotics if we have better materials or we can solve the problem of glove puncture. These are some details of this study. If you're interested, I can send this study to you. But again, also they found a time dependency. The longer the surgical procedure was, the more likely it was that you have perforation rates. Now, what about the other way around? Bacteria from the patient to the surgeon. Here we also performed a second study 2 years ago in Germany where we looked into this matter. To make this very short, again, we found that a very high number, up to 32% of gloves were punctured. 80% of these punctures were undetected by surgical team members. They didn't know that there is a puncture. And what we found here was that 5% of bacteria in an infected surgical site will be found on the hand of the surgeon after the procedure. So also we could demonstrate that bacteria or microorganisms, they will come from the surgical site to the hand of surgeons. And for colorectal surgeons, for instance, this is a very familiar phenomenon. Even when you have the feeling that there is no glove puncture, after the surgical procedure, you can smell sometimes a fecal odor on your fingers, which shows that there is a transmission of material to your hands. Now, what about the relevance for the surgeon or the team members? Infections in this field are usually transferred as stick injuries, and stick injuries can either be percutaneously, where a sharp object goes into the tissue, or where blood gets in contact with skin, but unfortunately skin is not always tight. There are small wounds, there are small lacerations, and we call this then mucocutaneous exposure. And the biggest risk, of course, is the fear of hepatitis B, HIV, and hepatitis C. Now, if you look into the infectivity of these organisms, you will see that the risk of getting a hepatitis B infection, if somebody is not vaccinated and has not a protective titer, is up to 40%. So 100 people who would get sick with hepatitis B containing blood, 1 milliliter of blood, 40 of them would get hepatitis B. For hepatitis C, the infectivity is about 10%. And for HIV, you would need to have 1,000 people where you stick in blood with HIV virus, and 3 would develop HIV. Interestingly, if you look at this correlation, it's directly opposite to the psychological fear, because the biggest fear, of course, is to get HIV, then hepatitis C, and today most people are vaccinated, particularly in healthcare, against hepatitis B. But this is, of course, an issue. Now, what are the strategies to prevent surgical site infections and healthcare infections? The big strategy so far was using antibiotics. When Fleming discovered penicillin G, and after 1941, when it was used the first time, we only relied on giving the patient antibiotics. Not only when he had an infection, but before that. The problem now is this strategy worked very well for the last 6 decades. But today, if you look at the MRSA rates with the methicillin-resistant staphylococci, the resistance is increasing, and increasing. In countries like in Portugal, for instance, you have already far more than 50% of MRSA among all staphylococci. So bacterial resistance is a huge problem, and now we are going to lose our only strategy to prevent infection, which is antibiotics. So we need to have new concepts here. And what I always say is, if we rely to prevent infection only on antibiotics, it is like driving a car with no brakes, but we say we have an airbag anyway if something happens. And therefore, what was started by the United States Center for Disease Control and Prevention and picked up by WHO, World Health Organization, is a multi-barrier system. We don't rely on one factor anymore. We need to put many issues here in place to prevent a surgical site infection. This is correct skin antiseptics, the surgical skill, sterile instruments, aseptic work, surgical gloves, glucose control, antimicrobials, patient warming, which has been identified as an important factor. And also we can combine these factors, like what is new, and I'm going to present this very, very soon to you, are now antimicrobial surgical gloves. Now, I will skip this because there are many, many clear rules. These are the rules which are commonly recommended, like immediate changing in case of notice breach, change gloves after 90 minutes during surgical procedure. Many people, many surgeons, they apply this, some they don't. The double gloving, for instance, a huge issue, is increasing now. But there's so many questions which we still need to explore, where we scientifically don't know the answer. When? Always? Do you always put double gloves on in selected cases, if you know that the patient has an infection? Or what is the strategy? You don't find any recommendations from any international surgical society in the world which really can answer this. We don't know. Also, I might skip this now. Now, what might be new in future, new technologies to solve the problem, is to use an antimicrobial surgical glove, which is able to kill off microorganisms entering the space between the hand and the glove. So these are able to protect members of the surgical team, but also the other way around. If you have an antimicrobial glove and you operate with this, this is like while you do your surgical procedure, you disinfect your hand constantly. So if there is a breach, the number of bacteria which are shed into the surgical site is reduced significantly. And we tested this in a very easy procedure. You put on one antimicrobial glove and one standard sterile glove. You wear it for 10 minutes, for instance. You take the glove off and you put your fingers on agar plates. I think this is very difficult to see, but you have to believe me. Here you wouldn't see any growth, and here you see bacterial colonies. So you can prevent the growth of bacteria on your hands during surgical procedures. Now, here, I hope I'm still in time. I did it sharp in 20 minutes, but I will end with a very, very old idea from Louis Pasteur, who said, instead of trying to kill bacteria in a wound, wouldn't it be easier if they never had entered the wound in the first place? I thank you very much for your attention.